Okay, so this video then we're going to kind of focus on the different types of eating disorders and kind of consider their characteristics, and I'll just ask you some questions surrounding them. So the first question, absolute back to basics, please will you tell me about the different sorts of eating disorders?
Well, I guess thinking from the perspective of our service, we're commissioned to assess and treat, I guess, the four main groups, and that they would include anorexia nervosa, which for us is the most common because it's the most common in adolescents, but actually represents about 15% of all of the eating disorders. Then there's bulimia nervosa, there's binge eating disorder, which again is the eating disorder that's particularly common in men. And then there's another odd group, which is called other specified feeding and eating disorders. And I guess that's essentially an opportunity which has been recognised in the reclassification of these eating disorders, of the need to consider people who haven't quite met the diagnostic criteria that are, maybe a bit strict for the other groups. But actually there's a significant level of psychopathology and physical pathology. So they're kind of like subclinical cases. And I think what people have found is that actually the highest percentage of eating disorders presenting, particularly in COVID, would fall into that group. The next group, which is not a group that we're currently commissioned to see, is ARFID, which is the bizarrely named eating disorder, which covers sort of a mixed bag of conditions, but essentially is looking at people who are described as having this aversive, avoidant refusal food intake disorder. So it's very much about people who probably have no interest in eating, or for a variety of reasons might be underweight, might not be, but aren't particularly interested or bothered about their weight, but have no real interest in food, and may come to the attention of clinicians because they're not growing to their centiles, or they are chronically underweight, or nutritionally deficient in some way, or may have had some aversive experience that means that they can't allow themselves to eat and are having to survive on supplements. A significant proportion of those patients will also have a comorbid neurodiverse diagnosis.
Okay, excellent. And then I suppose I'll ask you to kind of elaborate more on the characteristics of these eating disorders. So maybe if we start with what are the characteristics of anorexia?
Well, I guess anorexia is perhaps the disorder that people are more aware of. Perhaps peak age of onset is between 13 and 18 years of age, and it's characterized by weight loss or failure to gain weight because of extreme restriction and extreme dietary restriction. People may present with low body weight, but I guess, as I was saying earlier, that there's been a recognition within the classification systems that actually people may present with a normal weight. I guess in children we tend to go by the percentage BMI, so anything less than 85% of the median BMI worked out between the correlation between your height and weight. Anything below 85% people would consider it to be significant, and for adults we sort of usually use BMI, and that's 17.5 tends to be the guiding figure. But there's usually extreme anxiety and concern about body shape, weight, and distortion of body image. So what the patient might see when they look in the mirror is very different from what actually everybody else would see. They're often very low in weight and quite emaciated, but see a very obese individual when they look at themselves in the mirror. And it's associated with a lot of compensatory behaviours to try and reduce weight. So sometimes there are two subtypes in anorexia. There's the straightforward restrictive type, where there's serious dietary restriction, often to very, very low calorie intake, so often down to sort of 500 calories and kilocalories a day and less, which of course isn't compatible with sort of a healthy lifestyle. Other people may also excessively exercise as a means of losing weight. There's a binge purge profile. Some people purge without the binge, but again, there's a different subtype, or but all still anorexic, and may also be associated with laxative abuse, diet pills, and And I guess what's also very prominent is the kind of intense anxiety and shame, low self-esteem associated with their whole view of themselves, often quite perfectionistic and high achievers, often very bright, but an intense fear of gaining weight, intense fear of becoming fat, and an over-evaluation of themselves and their own worth in terms of their weight and their shape. So that's anorexia. I guess what's useful to think about is how what the effect of starvation is on the body, and I guess it's a multi-system sort of impact. And depending on the severity of the anorexia, we'd notice that sometimes people are a bit slow in sort of their cognitions, that they can't think and decide as quickly. And they're often very preoccupied and completely focused on just eating and the need to lose weight. And it's associated with changes in the brain chemistry, as well as I was saying earlier about sort of dopamine. Then moving down through the systems, where the particular concerns of the cardiovascular changes because of the loss of, the loss of the insulation means that the person feels very cold. They then means that they have to use muscle as a source of energy, body being quite adaptive, but it means then that you lose your heart muscle as well as the skeletal muscles, so that the cardiovascular function, it can be quite compromised. So there's difficulty perfusing out to the peripheries, as well as maybe sometimes some fainting, dizziness, and the experience of palpitation. So quite worried about, and the heart rate often slows down considerably to try and compensate for all of the changes that it's trying to navigate. And again, this can be quite dangerous if there are palpitations, and arrhythmias can be a significant problem. If the person is purging, then they're likely to be losing, important electrolytes such as potassium. So again, these compound the cardiovascular problems as well. So working down through the body, often the skin is dry and brittle, nails again quite brittle, the poor healing. Often there's quite delayed gastric emptying, so it takes a long time for everything to move through the system. People often then end up quite constipated, may have some abdominal pain. If there's very significant weight loss, there's often loss of the fat pads that kind of protect the spine and the various organs and blood vessels from having to, from the impact of lying against those. And so there's often quite severe pain associated with that, and particular syndromes, until these pads are replaced and people are refed. One of the significant changes to the skeleton can be because of the loss of periods, and what they call the hypopituitarism because of the impact of starvation. There are no periods, there are no estrogen, so very difficult for the calcium that should be going in and out of the bones to remain in the bones. So actually bones are in danger of becoming quite brittle and weak. What else? I've left out a system and I've forgotten which one it is. Bone marrow suppression. I knew there was something else in the bones. So that's sometimes we see a low white cell count. That's often quite an important marker where it is low, particularly if it's the particular white cells, the polymorphonuclear, the neutrophils, which are a good marker for people who are vulnerable to refeeding syndrome. So actually, when people are first assessed, it's really important to know their status so that we can be alert to how vulnerable they might be to refeeding syndrome. So that's sort of anorexia.
Can I ask you next then about bulimia nervosa?
You can indeed. Peak age of onset is about 15 to 19, so we tend to see fewer of those in our clinic as we go up to 19. But we are beginning to see a few more, and sometimes seeing a few more boys presenting with that. Again, I guess people are kind of reasonably familiar with sort of what the pattern is. Recurrent episodes of binge eating, and then inappropriate compensatory behaviours to try and mitigate sort of any weight gain. Weight can be variable, can be, you know, high, low, normal, and this is one of the disorders that has some criteria, so you have to have at least one episode of binging and purging a week, and there has to be every week for 3 months. And I guess it's within those criteria that OSFED sort of picks up the people who perhaps don't quite fit these criteria. The binging has to be an unusually large amount that, you know, and it may be over a period of 2 hours, so that, you know, an unusual amount that ordinary people wouldn't think that they'd eat quite so much, and it's in a sort of a relatively short period of time, and the feeling of loss of control over the eating is very important, and then frequently associated with a lot of shame and guilt. So often people are quite covert about their eating disorder symptoms and find it hard to share. The aspects that are particularly tricky are the compensatory behaviours. Often there's abuse of laxatives, diuretics, diet pills. Purging is particularly a problem, so the impact of losing the electrolytes has a major impact on the homeostasis system. People often exercise to, you know, excessive degrees, and often there's a pattern of sort of restriction and then binging, which of course is tricky for the body to kind of to compensate for, and particularly thinking of insulin. Again, the overvaluation of oneself in terms of weight, shape is a core feature. Going backwards, opening the papers, here we go. And thinking about the impact, some of it is quite similar depending on sort of where people's weight might be, similar in some ways to some of the consequences for anorexia. I guess the electrolyte imbalances and the pH imbalance is particularly a feature because of the purging, and there's no natural way of replacing the lost acid. And then the consequences of so much purging, for you sort of right down from your teeth, with all the damage to enamel and esophagitis, and, you know, to the danger of actual rupture at the esophageal junction. So it's quite I guess people often get into quite a pattern of purging, but actually it's quite a dangerous compensatory behaviour. I guess the consequences of the electrolyte imbalance are evident sometimes in the cardiovascular system, but usually less so because than anorexia. Again, the impact on periods can be variable, and again on the digestive system. You know, some people can be constipated because of the excessive use of laxatives, and it can have a detrimental effect on the bowel. They used to talk quite a lot about that people with bulimia who were purging consistently, that there was some kind of evident swelling of their parotid gland. So parotid gland enlargement was meant to be an early indicator, as well as the Russell sign, the kind of the calluses on people's knuckles because of the method that they use to force themselves to vomit.
Okay, excellent. Thanks for that, Catherine. So my next question then is, please can you describe the characteristics of binge eating disorder?
Yes, binge eating disorder is perhaps has been around, but more of a new recruit to the classification system. Peak onset is usually sort of early adult life, though not exclusively. And I guess it's one of the disorders where men are particularly well represented. So about 43% of those presenting will be male. And this is characterised by recurrent, persistent episodes of binge eating without purging, but the episodes occurring again at least once a week and every week for 3 months. And again, the binge is an unusually large amount of volume of food in a brief period of time, and then associated with loss of control over the the eating, and then associated with shame, guilt, distress subsequently. The lack of the absence of the compensatory behaviours, such as the purging, exercising, is one of the features that distinguish it from bulimia. And they tend not to be the same abnormal body-related cognitions. I guess it tends not to be one of the disorders that we see very much of because of the predicted late age of onset.